Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, we have a fascinating discussion on hemodynamics, ultrasound, a 4-quadrant model for characterizing patients' physiologic milieu. It's going to be amazing. And I just have to put out a warning. So you're going to hear 4 men on this panel, and I guess including me, it makes 5. And you'd be like, WTF, could you not get a little bit more diversity in this panel? And I will say that it was just supposed to be an interview with me and friend of the show, Phil Rolla. And then Phil surprised me by getting 3 of the other authors on his paper to come, unbeknownst to me. So that's how we had the uniformity in this panel. So please have that understanding. It is just happenstance that this occurred. But the discussion is fascinating, and I think you will truly enjoy it. Quick plug for the Reanimate Conference, our resuscitative ECMO conference in San Diego. Tickets are now on sale. If you've been waiting for us to open them up, they are now open. Let's get right into the show. Why don't you quickly tell us who you are and what you do, and we'll go in the order I call out. Phil, tell us who you are and what you do.
I'm an ICU guy working out of a little community shop in Montreal, Santa Cabrini Hospital, and I love all things POCUS and resus.
Love it. Corbin.
Hey, I'm an emergency medicine doctor. I work out at Riverside University Health System, Loma Linda University, and Desert Regional Medical Center.
All right, John.
My background is pulmonary critical care medicine. In 2018, I left to run my startup.
All right, and Rory.
I do both emergency medicine and critical care. I split my time about 50-50.
All right, I love it. Now, you all wrote an article called Unifying Fluid Responsiveness and Tolerance with Physiology, a dynamic interpretation of the Diamond-Forrester classification. First off, who could jump in and say why this article was written? And if you had to give an elevator pitch for why it's important to read, who could do that?
Give that one to John.
All right, John, you were the lead author. Tell us, man.
All right. It's a good question. The elevator pitch would be the Frank-Starling curve has 2 axes. The X is cardiac filling. The Y is eventually cardiac output. If you're resuscitating only on one of those axes here, it's a one-dimensional approach, and this is a 2-dimensional approach to resuscitation.
All right. And you integrated the new idea of VEXUS along with a non-invasive measure of cardiac output, namely LVOT VTI, and then you superimpose those on the Diamond-Forrester profile, which is a remnant of clinical bedside medicine that then was taken into the numbers you'd get from a SWAN PA catheter, namely the pulmonary artery occlusion pressure and the cardiac index. And that classified patients into 4 categories we always had at the bedside, which were warm or cold, and then wet or dry, with warm being potentially okay cardiac output for that moment in time, cold being poor cardiac output, and the wet and dry not being what you typically think for bedside emergency medicine, which is the patient diaphoretic or not, but more a marker of how much backfilling there is to the lungs in the form of pulmonary edema. And so I guess the first question I ask is, have you changed Diamond-Forrester by using VEXUS, which is now a marker not just of left heart failure, but it could be left heart failure, it could be right heart failure, it could be a combo, or it could be right heart failure alone. And how does that interplay with the classic Diamond-Forrester classification?
I'll hop in on this one because it's an easy one. I think we could actually use any number of things, and I think that was the point. Like you could use VTI, you could use cardiac output, you could use on any one scale, you could even use stroke volume if you really wanted to. On the other one, you could put on the venous side, if you will, congestion side, you could use long ultrasound, you could use CVP, but basically that you don't just look at a forward flow issue, but you look at the congestion side as well. And I think it's more important as a concept so that people can even auscultate, do whatever they may be, but have that conceptual model of trying to place their patient in one of the 4 quadrants and then follow along as they're doing their resus.
Yeah. Does anyone else want to add to that?
Yeah, the stuff actually will tell you what's going on with the left ventricle as well, as long as that back pressure is affecting the right ventricle. Also, we're pretty much interested with this group here in venous congestion and its effect on hemodynamics. So it was a nice one to include in the analysis.
So I'd love to go through each quadrant and hear your thoughts on both the diagnostic take home we're supposed to get when we classify a patient that quadrant, and then what actual clinical steps at the bedside that quadrant would indicate may be some good things to try. And let's start with warm and dry. Now, this is a patient with classically a normal cardiac index and a normal pulmonary artery occlusion pressure. In your new classification, it's a patient with a VTI greater than or equal to 18. We'll talk about the gray zone of that in a little bit. And a Vexus of 0 and 1, meaning minimal or no venous congestion. So what do we do with a patient who is warm and dry?
Warm and dry patient is someone who probably needs a vasopressor. You could treat, and I think most people actually do treat with fluids in these patients initially, but the idea is that they don't have venous congestion. They do have a high stroke volume. So the afterloading is probably down, but the preloading is adequate to give you enough stroke volume, as opposed to Quadrant 3, where you may not have enough preload to give you that stroke volume.
This is, of course, assuming that there's shock in general, right? Like we all
Correct.
walk around in this state where you have a normal cardiac output and a Vexus of 0 or 1.
Yeah, that's a fantastic point. And let's go with, from everything we're going to talk about in this point, the patient's hypotensive, or at least has what you feel is evidence of a shock state, because I think that is where it becomes relevant. So thank you, Rory. That's perfect. Arguably, this is your classic septic patient early on. And as you alluded to, Corbin, we usually start with fluid loading. Just from a physiologic perspective, that doesn't make a whole lot of sense, right? Physiologically, this quadrant would tell us this patient needs additional vasoconstriction. And we know that's going to have venous side constriction as well. Arguably, it's going to give an infusion of increased preload simply by changing unstressed to stress volume. So why are we giving fluid to these patients in this quadrant?
I think that's an administrative answer, because I guess if you can get away with a little bit of fluids and avoid pressors and therefore monitored bed admission, then you might have a small administrative gain, but you're absolutely right. Physiologically, it doesn't make sense.
Right. John, you smiled. Do you want to say something to this? Or?
Well, I was going to say, because the Veterans campaign told us to.
There we go. Now, a point was made in this paper that I think is incredibly important, which is that just because they're in this quadrant before you start vasopressors doesn't mean they'll stay there. And it's really easy for the heart to have this beautiful ejection fraction, beautiful cardiac index, generating great stroke volume when there's no afterload it's pumping against. And as soon as you change that, you might change your quadrant. So how soon after treating Quadrant 1 should you be reassessing at the bedside?
Personally, I test every time I do something. I've seen patients who have some subtle ventricular dysfunction. Once they're faced with a pressor, suddenly drop down and have some dysfunctions. It's in sepsis, we have all kinds of hemodynamic problems and abnormalities and stuff. And some of them are actually hidden because the afterloading is often, decreased, and that can hide ventricular dysfunction.
Quadrant 2 is warm and wet. Now, classically, this was a normal cardiac index, but a high pulmonary occlusion pressure, meaning they're probably going to be developing interstitial edema, eventually frank pulmonary edema. In your classification, it's an LVOT, VTI greater than 18 or greater than equal to 18, and a Vexus score of 2 or 3, meaning actual venous congestion. Now, arguably, you guys are more specific and less sensitive to LV failure if you're using the Vexus score, because if it was pure LV failure, it would take a while to actually hit to the point of RV failure and then increase CVP. So by the time you get to warm and wet on this new classification, things are really bad. So you folks would argue that in addition to starting a vasoconstrictor, you might want to take additional steps in therapy. What would those steps be? Rory, you've been nominated.
So obviously a vasopressor, and then your next two steps are whether you start inotropy or diuresis, depending on, I think, the state of their shock, where they are in their resuscitation, and how soon you think you'll have source control.
Now, this is interesting because classically, the warm category meant they had decent cardiac output. This emerged from the bedside where you'd feel their extremities, you check their cap refill, and you say, whatever else is going on with their hypotension, this patient's cardiac output is okay right now. And then you look at the fact that their congestion, you say, either we've fluid overloaded them, so their cardiac index just isn't up to the iatrogenic burden we've placed on them by giving them way too many fluids, or we may say that they have a relative cardiac insufficiency, which is, I think, what you're alluding to, Roy. But in this circumstance, we would be sending them to a supranormal cardiac index to give them inotropes in this case, or at least we'd be verging on that. And now we're starting to get to the olden days of let's give dobutamine for funsies. How do you respond to that?
Yeah, I think it's entirely patient specific, and there are some factors that play into this that are outside the variables that were given in this paper. The best example is heart rate, right? Like even if you have a reasonable VTI, but you're squeezing at like 40 and you're in shock and you just think that the overall cardiac output is down, giving them an inotrope for its chronotropy in and of itself can give you some aid. And so I think you just have to take into account what the patient is what you're dealing with, and whether you're moving more towards the idea of adding an inotrope.
It's a good answer because we have quite a bit of literature saying now the main effects of an agent like dobutamine and potentially even epi in sepsis, in contradistinction to cardiogenic shock, is simply to increase heart rate, that you're not getting any pure inotropic effects. And so if they were going at a relatively slow heart rate, it would make a lot of sense to grab what you can in those circumstances by just knocking their heart rate up to slightly greater than normal. And I think that's what you're saying. Is that correct, Rory?
Yeah, and this is exactly what in these patients that whatever reason just can't mount a good heart rate, whether they have a sick heart or are on some beta blockers or something, and they've got a vasodilatory hit like sepsis, and you're just not mounting what you need.
You know, this brings up a slightly tangential question, but we're talking about it, and I have some of the smartest people in critical care on the line, so let's find out. Let's say you have a patient. They're not severely bad on their cardiac history, but they're a little older. Let's say you have a 70-year-old patient. Where would you, if they're evidencing poor tissue perfusion, what heart rate would you like them sitting at? You don't obviously pin yourself down to a real number in clinical care, but if I forced you to, give me a number. Where would you like to see that patient's heart rate sitting? They have an elevated lactate. They're showing some signs of not really getting as much organ perfusion as you like. What heart rate would you ideally have them at? Let's go around. Phil, just rapid fire.
I probably sit somewhere between 90 and 105, something like that.
All right, John.
Yeah, probably on the lower end of that frame, just because the myocardium perfuses during diastole.
Corbin?
I'd pick a heart rate that is good for whatever my stroke volume is. I want to make sure that I have an adequate cardiac output. What is that? That's a little bit hard to say, but I think that the targets that have been put, Phil said, is probably pretty close to where I'm going for.
Love it. Rory?
Higher than it is right at the moment. And then it's like we talked about follow-up and see if what you got seemed like you have more perfusion, right? Whether it's mentation or tissue perfusion or so forth.
All right, good. Now, you folks made a point in the paper to say that a patient who is fluid unresponsive may be a better candidate for diuresis in this quadrant than a patient who is fluid responsive, with the idea arguably being that fluid responsiveness in this case is indicating not that they necessarily need fluid, but that they're not quite as clear-cut a case as a patient who is beyond responsiveness to fluid. Now, my first question in this, isn't Vexus telling us that already? And if not, then I want to make clear my interpretation of this was that doesn't mean you'll give this patient fluid. It just means it's a test. And so maybe fluid responsiveness is not the best name for this determination we're making right now. But who could speak to those two questions? John, you were holding up your hand. Maybe you hit those first.
Sure. I think it's a really excellent point. I think it's just borrowing from the French group that looked at fluid responsiveness, or I guess you could really call it testing for fluid unresponsiveness to guide the probability of intradialytic hypotension, with the idea that if you're on the ascending portion of the Starling curve, so you are fluid responsive, and you start to decongest or diurese that patient, they're more likely to fall down the curve, decrease their stroke volume, and then with the falling flow, they could get hypotensive. Whereas the patients that were unresponsive, you could diurese them and there is less of a risk of that hypotension. And a similar physiology played out, they studied in weaning from mechanical ventilation if the patient was congested. And I think that the important distinction here is that we will, as Vexus becomes more mainstream, we will start to see patients who have a high Vexus but are fluid responsive. We'll see patients that have a high Vexus that are fluid unresponsive. In theory, they're going to be more likely to be unresponsive than responsive. And we have some preliminary data to support that, but it's like a subphenotype. You could have a Vexus 2, 3, and then the subphenotype is, are they fluid responsive or unresponsive? I'm going to decongest them, but I want to know if I'm going to get into trouble with that first shot of LASIK. So
I love it. All right, I'm going to ask you guys another practical bedside question, rapid fire. If that's the case, if we're not ready to say Vexus is prime time for this particular question, then what test of fluid responsiveness are you actually using? Because we have a lot of Zen-tensivists here. So what are we actually going to use as our marker of fluid responsiveness in these patients? Rory, what are you using?
I honestly don't do this very often. I find clinically, while this phenotype is described, clinically, when you have a high Vexus score, you have so much venous return or venous congestion in return that they just don't get hypotensive. And most of the time, I just diurese them if the picture fits clinically, that's what they need.
All right. Rory's on my take as well. Corbin.
VTIs, that could be a LV, OTVTI or a RV OTVTI. You can do carotid flow times. You can even do weird stuff like splenic resistive index and stuff like that. So you can, if you have trouble with one or the other, you can work around it. And if you have a cardiac output monitor, you can, of course, use those too.
You got to give them something to see if they're responsive. What I'm asking is, since you guys have put in this question point of, are they fluid responsive or not, to judge whether to diurese a patient in the warm and wet, what would you actually be doing to figure out the answer to that question?
What goes along with the French group that did this as well is obviously those patients, it was all passive leg raise. So it's really validated in the passive leg raise population. And to your excellent point, you don't want to give them Restored to them.
All right. And so, Corbin, would you change your answer at all? Now,
absolutely. So a passive leg raise is one way to do that. The other thing is you can look for pulse pressure variation or stroke volume variation if you have a vented patient. Looking at the right ventricle, if you have a little bit of diastolic septal bounce, that implies that your right ventricle is on the flat part of the Starling curve, and it would be safe to diurese those patients, even if they're hypotensive, because being on that flat part of the curve, you're going to not lose any stroke volume with the loss of preload.
All right. Phil, do you want to add anything to this?
I think Corbin's is a great point. And as soon as you have some shift, if anything, it might probably is even going to be beneficial to your systemic hemodynamics, your arterial side, to take some fluid off. To be honest, I very rarely end up doing fluid responsiveness stuff because it's so often by the time I'm down in my mental algorithm deciding, and even in this subclassification of patients, I would probably just diurese them out. And certainly looking at the septum would be a tool there.
And we could always give it back.
Yeah, I would just add that last point that
go for it.
A Lasix challenge, there's nothing wrong with it. In fact, sometimes there's nothing wrong with them getting slightly hypotensive as you empty the venous side and let it fill from the lymphatic system, which is your intent anyway. You can temporize that with increasing your pressors to a small amount.
All right. Anything before we go to the next quadrant here? So then we get cold and dry, classically low cardiac index, low pulmonary artery occlusion pressure. In this case, a low VTI, a Vexus of 0.1 indicating minimal venous congestion. Now, these are patients, it's weird how to classify them because they are showing you poor cardiac output. And yet at this very moment in time, they haven't really backed up to the lungs. Now, in the old days, this could be a patient with poor right-sided function. Tell me about cold and dry.
This is an area where you actually need some dynamic assessment to figure out where you're at. The issue is that, is your stroke volume low because you don't have the preload? Is the stroke volume low because you have cardiac dysfunction? Or is the stroke volume low because you have too much afterload? And so you have to figure that out by giving them either a straight leg raise or a fluid challenge to see what happens to the stroke volume. So if you have a fluid challenge given and the Vexus goes up, but the VTI really doesn't, that's probably somebody that's going to wind up in quadrant 4 versus someone who goes up to quadrant 1. That person needed the preload challenge. This gets into the idea of how the ventricle is dealing with the afterloading conditions. I think some people may argue with me about this, but I think you actually can tell the distributive issue with lack of preload and no afterload versus the issue of just the other way around by looking at what your calculated systemic vascular resistance is. So if your SVR is high, you're probably on the low volume end. And if your SVR is low, you're on the distributed end. So that's why your preload's low.
All right. Anyone want to add to this? Go ahead, Phil.
My favorite quadrant. But
Yeah, it is a fun quadrant. The quick and dirty way that works, not 100% of the time, because there's a middle zone, but it's just putting hands on the patient, right? If you've got a patient who's generally warm or warm-ish, then you know that your SVR isn't that terribly high. And to me, more importantly, often is that you have recruitable volume that comes at little. So I always encourage and or chastise if they haven't done it, residents who come back and tell me about a lot of EF and all that, but they can't tell me if the patient is hot or cold to touch.
Last thing I would add is you could just qualitatively look at the heart too, right? Like we're talking a lot about the numbers, but how's it squeezing? Is it full? Is it empty? What's the RV doing? All those kind of things give you most of the way there, right? If you want to know if the patient has a low VTI because they just don't have any fluid in their heart to pump, you can tell by simply looking at it rather than doing a straight leg raise versus do they have a low VTI because their heart's just not beating so well?
Yeah, that's a good point. That's a good point. One problem that you sometimes go into is, for instance, say you have no afterload, your end diastolic volume is going to be low because the ejection is very efficient, versus if you're just not preloading, you're not going to have end diastolic volume that's big either. You can look at the EF, but sometimes it doesn't give you all the answers that you want.
I would just throw in too that you can commonly have a septic diastolic dysfunction. And you can have patients with normal EF, but if their relaxation is impaired, then they may not be fluid responsive and could just end up increasing their LVEDP with holds. And so I'd say that's probably phenotype that I wanted clinicians to recognize the most out of quadrant 3, which is why I call it my favorite quadrant, is that situation where you've got low venous return and maybe an evolving septic diastolic dysfunction where you could have low venous return from a high stress volume and it's intersecting with a poor cardiac function. So the venous signal is decongested or low pressure, however you want to measure it. But there is going to be a subset of patients in that quadrant that will congest very quickly with further preload.
All right, let's talk about cold and wet quadrant. This is a patient with low cardiac index, high pulmonary artery occlusion pressure. Classically now they have both high VEXUS and low LVOT VTI. What do you want done in these patients?
These are generally patients you're going to want to help their squeeze a little bit, but obviously you have to taken a look at it, ruled out all the other problems. Because, and I think one of the things about this is not to think of the exclusive framework of your resuscitation, no matter what you put on these axes, right? But that it's just part of conceptualization. And I think perhaps more importantly, which direction of these quadrants as you do your resus are these patients going to go? But in that quadrant, to get back to that, those are the patients who probably need a little help with their squeeze.
Anyone else want to talk about cold and wet?
Yeah, you can test and see what happens to you. For instance, your VEXUS or your central venous pressure. If an inotrope was the right answer, you should probably see you drop down back to quadrant 3 or even quadrant 1 if everything's going great.
Anyone else? All right.
They will obviously sometimes benefit from diuresis as well, right? If they truly are on that flat part of the Starling curve, inotropes and diuresis sometimes in combination help here.
Now, you folks, very
one,
nice.
One point.
Go ahead.
Sorry, Rory's report is really excellent. I think one thing that is lost is that in the diagram in the paper, we demonstrate all these different curves, but in theory, there's like an infinite number of curves between those two extremes, and they're really dynamic. They change rapidly. And so I think to Rory's point, you can have a situation where you diurese somebody and the curve actually starts to shift up and to the left just because you're decongesting the LV and you're improving its geometry and its ability to generate a change in pressure. Just the act of giving Lasix could shift that Starling curve up into the left and actually act like an inotrope in some kind of strange way.
Now, you folks nicely in the article point out that we've given absolutes in the VTI up until now, dichotomized around 18, but in most people's hands, if they're not truly expert, there's some fuzziness around that. And you might want to say less than 16 is poor cardiac output. Greater than 20 is definitively normal or supernormal. And the in-between, you really need to use some additional factors to make your determinations, because just the beat-to-beat measurements, the between session measurement, especially if you don't mark the chest and keep them in the same position, it's going to be tough to reproduce perfectly. All right. Is there anything else you want to add from this paper that we haven't already discussed?
Can I give a plug for our preliminary data?
Yes, please.
So we have one paper that was just accepted, that will be out soon, where we tried to, through another way of assessing these quadrants for the degree of venous congestion and fluid responsiveness, we wanted to characterize the rates of fluid responsiveness in each quadrant at baseline. And so it's very preliminary. It's only about 40 patients in an emergency department, very small, caveats galore. But what we found was that the responsive to unresponsiveness rates in quadrant 1 through 4 was 80%, 20% responsive to unresponsive if you started in 1. If you were in 2, you were 50-50. So it's kind of like ICU literature, responsive to unresponsive. In 3, it was 67 to 33 responsive to unresponsive. So still more likely responsive than not, but follows some of the CVP literature. And then in quadrant 4, the cold, wet, bad heart, the responsive to unresponsive rate was 33 to 67%. So So it's a small number of patients, but it's, I think, interesting preliminary work that could suggest how some of the forthcoming VEXUS literature.
I love it, but I will put the proviso that just because a patient's fluid responsive does not mean they need fluid. And you folks all know that, but I want to make sure the listeners know that as well.
I want that to be screamed from every...
All right, let's hit IVC real quick. The paper is fantastic. I think everyone should read it. One of the key points I want to get discussed is, okay, after all the stuff you wrote, where and how should we be looking at the IVC with ultrasound? Phil, why don't you start us off here?
Sure. I think it's simple. We're all able to eyeball an LV. I think there's literature to support that we can do it. If anything, eyeballing the IVC should be easier. I think basically you should short axis the IVC from the junction to the right atrium all the way until you can't see it. And to me, you eyeball that, you watch that as the patient's breathing, you quantify is these respiratory efforts, do these changes in pleural pressure, are they high or normal? And that's how I like to make my idea about what I think the IVC is like.
Anyone want to add?
I just add that you don't have to look at it in one view, right? We don't look at the heart in one view. You can look at the IVC in multiple views. So you can look at it in longitudinal, you can look at it in transverse, and you can get a kind of global idea of what you're seeing.
Yeah, I see something that happens all the time that bothers me, and that's using the IVC as a preload test. It's not. It just doesn't work very well for that. For me, the IVC is more of a be careful indicator rather than something I would use to give fluids.
Yeah, and in fact, the Canadian Journal of Emergency Medicine published the shock IVC paper, right, coincident with the publication of this paper, and it said the same thing. The likelihood ratio positive was fantastic for venous congestion for a plethoric non-respiratophasic IVC, but for everything else, it's just not there. And so if your IVC stops moving and it's big, you've probably gone too far, except in one circumstance, which is a patient with right-sided heart failure. And now in the paper, there was a tantalizing thing that said, but you could still evaluate it using the plethoric index mentioned earlier in the paper. And I don't know, maybe I missed it, but nowhere in the paper is this plethoric index mentioned. So tell me, what is the plethoric index?
Oops, did we miss that? Basically, it's just how circular is it and with minimal variation. But did we really not include that? Oh, man.
Not by name. You might have included the idea, but that's what you meant. Because the only instance of the words plethoric index was in the spot of alluding to it being there earlier. So you're saying, so then tell us outright, how would you evaluate an IVC in a patient with known high pulmonary artery pressures? They have pulmonary hypertension. So they're going to have a big plethoric IVC. How do you know for that patient whether this is normal or this is an abnormal situation?
I think that those patients normally have a plethoric IVC. They essentially live there. So anything that's sometimes you'll see, let's say you see, I've seen IVCs are at 4 centimeters, these terrible, either congenital or terrible long-term pulmonary hypertensions. Anything below that and with a significant amount of respiratory variation probably isn't normal for that patient. And they're probably on the low side of their required pressure volume relationship. That's why I'm a little bit loath to use an absolute cutoff of 20 millimeters. I know we did that for VEXUS, but I think that's just the data that we had. I was actually just earlier today talking to a guy in Thailand who's been doing tons of VEXUS, and he's just, I'm a little bit concerned that in my Asian population, 20 millimeters might be a bit much. And I totally agree with him. It's tiny little ladies, it may be 16, 17 millimeters, they're plethoric. You should go ahead and VEXUS them or do the rest of the stuff because that may be as big as it gets for them, at least on a semi-acute short-term stage. It's very tough. I think pulmonary hypertension is an area, severe pulmonary hypertension is an area where a lot more research needs to be in terms of what's the VEXUS, what's the optimal VEXUS, whether you just need to try potentially if they clearly have congestive dysfunction, organ dysfunction, it may be just getting them just a little less VEXUS, like a 2.7 or something like that may be the way to go. I think that's a huge gray zone still.
I love it. But what you did say, if I wanted to piece it out, is that if this was their normal, they would have respiratophasic variation because that would be their new baseline. They might have a big IVC regardless, but it's probably abnormal for them to no longer have the respiratophasic variation. Is that correct, Phil?
Correct.
Okay.
Can I add one more thought to that?
Please.
Just with the pulmonary hypertension in patients with right heart failure. It gets into this kind of idea that we have with the Bayesian idea of fluid analysis, where there's a risk benefit that goes beyond most of these tests, and it goes to the disease state they have and their comorbidities and so forth. And risk benefits of fluids in patients with pulmonary hypertension is a fairly steep curve, right? Like you get onto risk really quickly. And so you have to be really careful with giving any fluids. And even if you look at the data on this, most of the time they're volume up when they get into trouble. When they come to you in ED, they're volume up almost always. And so you need a lot of signs to shift you towards it's okay to give this person fluid. And whether that's Vexus, the story, you want to have multiple factors showing that you're a Vexus 1, you have been vomiting for days, lots of things that give you a reason why this patient could benefit from fluid. Whereas almost always Lasix is going to be your answer in these patients.
There you go. I love that. All right. Anything we have missed that you folks want to discuss?
I think if we want to drum something out there again, is not using the IVC as a fuel gauge for fluids. I think that's what we see all too much. We hear, hey, there was space. IVC was varying. There was still a lot of space, and I just go on and go, oh no. So I think that's the main message, is it's not a fuel gauge for volume.
I don't know how bad my internet connection is right now, but I'll have a letter to the editor on that. Canadian Journal of Emergency Medicine out. It's just accepted today. So
what is the content of that letter?
Just reiterating a lot of the points here in terms of using IVC as a marker of volume status.
We've discussed this before. I think Phil and I have discussed this, but all of this Vexus stuff just makes me say, if I put in an IJ, there's no reason not to throw a CVP up there. And the same way we reversed our ideas on IVC, it's now no longer a marker of keep loading until it stops moving, but quite the opposite. If it stopped moving, a major problem has been created here. Let's fix it. CVP becomes a very valuable marker when it's used as a sign of venous congestion. And it's a freebie if they have a neckline. And I think people have moved away from it entirely due to the stigma cast upon it by its misuse in the surviving sepsis era. But I think it should be brought back. It's now an immediate bedside marker of, wow, I went off shift 8 hours later, I came back, something horrible has been done to my patient. So what's your thoughts on that, gentlemen?
We've known this for years, since the FACT trial was published. When we looked at SWANs, the interesting part of the FACT trial was you were randomized to either get a SWAN or a CVP in the management of your fluid therapy. And these were patients with ARDS and most often with sepsis as well. But it didn't matter. It didn't matter whether you had a SWAN, didn't matter whether you had a CVP. What it did matter was when you decided to stop giving fluid, and whether you had the SWAN or the CVP, as long as you used it as a stopping marker rather than a resuscitation marker to push towards, the patients had far better outcome. But yeah, I think we've had this data for a while. Much like the SWAN, it wasn't the SWAN's fault. It was our resuscitation strategies. It's the same with the CVP, right? If you're using it to resuscitate rather than to tell you when to stop, it becomes a dangerous tool.
Yeah, I love the CVP. I think it's one of the most useful parameters we have. And it needs to be actually a dynamic parameter, not a static parameter. And beyond just the number, the waveform. If you understand the waveform, then you really can understand where your right ventricle is on its end diastolic elastance. The right ventricle is okay for taking fluids up to a certain point, but once it gets to that sort of sharp break point of where it's reached the end of its where it can take fluids, the CVPs rapidly go up. And so you can see that coming actually if you're paying attention to the waveform before the number even goes up.
John, you wanted to say something.
And you could, thanks. You could integrate the CVP into our position paper as well. You could, your dry versus wet, all of those terms are terrible. Pick your number, 8 millimeters of mercury, 10 millimeters of mercury. It's known that the higher the more likely you are to be on the flat portion of your Starling curve. The real issue with the CVP is the lower CVPs. There's still patients that are on the flat portion of our Starling, or even with low CVPs. So that's what doomed it in the last 20 years of using CVP as a marker of fluid responsiveness. It just doesn't work at the lower ends. At the higher ends, you're thinking, why the hell am I giving this patient more preload? Which is a very appropriate way to think about it.
I love that. Perhaps we'll finish with something that this naturally leads into, which is, has the PA catheter been falsely maligned? Pac-Man looked at indices I did not care about. I don't care about pulmonary arterial occlusion pressure. And the ones that I do care about, things like SVO2, were never really evaluated in clinical trial that I know of. My experience in the CTICU is SWANs could be incredibly valuable for certain patients, and they've just been killed by clinical medicine right now. What's your take?
The irony of this is we did all these studies and they essentially showed that the resuscitated strategy you're using with SWANs didn't work. And we got rid of the swan, but we kept the resuscitation strategy and just found new non-invasive ways to do the same thing. And so I think what most of us in Vexus has been doing is trying to shift that resuscitation strategy, right? Trying to move away from this forward flow, oxygen delivery, fluid responsiveness to a fluid tolerant, intolerance, risk versus benefit. You can use whatever tools you want, whether it's a swan, whether it's ultrasound. For the most part, I don't work in a CV ICU. I use an ultrasound, and I find very few times do I actually need a swan to get that information. But
hey, folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
yeah, as long as you're using the right strategy, it doesn't really matter what tool you're using to get that info.
I love it. Anyone want to add to that before we disappear?
I definitely agree with all that's been said. I think the swan remains a nice tool. I think one advantage it has over ultrasound once you've married the data, because you need to do that to get around the pressure volume paradigms, is that it's a superior monitoring tool when you're not at the bedside with your probe. If you're at home, we do home call from the ICU, and then I like to get my, whether I'm getting CVPs or my PAPs, depending on what I've done, and to be able to track those things. And I think marrying the two together gives you a really powerful hemodynamic assessment.
Wow. I can't thank you, gentlemen, enough. We've hit the hour mark. I think that's probably more physiology past this that no human being who's not you four could take. But this has been incredible. I did not know going into this that I would get all four of you, and I'm so happy I did. It's fantastic to have you on. All right. I'm sure more to come. Keep writing papers. We'll keep talking about them. All right, folks, there you go. If you want to see the actual papers mentioned or you want additional information, just go to the show notes for this episode, emcrit.org/367. Before I say goodbye, let me just mention Medicine Coaching. That's my physician, executive, and performance coaching service. And I want to highlight this month, if you are a problem child, if you are getting in trouble at work, if you are not having the greatest relations with your colleagues, the nurses, you're being told by administration, you better shape up or it's going to be a problem. Maybe you've actually been given warnings. Now is the time to invest in some coaching to turn that all around. We could do things like 360-degree surveys to figure out why people are having the impressions they're having. We could do behavioral counseling such that you could save your job and not get to the point where you now have these strikes on your record. So if that's of interest to you, then come to emcrit.org/coach. That's emcrit.org/coach, and we will get you set up. This has been Scott Weingart from the EMCrit podcast saying bye-bye.